But for those of you who haven't spoken to, my name's Becca, and as Francisco said, I work at St Thomas's Hospital in London, and I'm going to be presenting to you a piece of work which I've been involved with for the last 3 years. So, just to draw you into my study and where I work, what I do, I'm a clinical physiotherapist, and I work at St Thomas's Hospital in London. St Thomas's Hospital is situated opposite the Houses of Parliament, and it's very beautiful. It's a very famous hospital. Florence Nightingale used to walk up and down our corridors, and she revolutionised nursing care. Where we are located is on the border of Lambeth and Southwark, which are the two highest prevalence boroughs for people living with HIV in the UK. So Lambeth is 13 per 1,000 population, and Southwark is 10 per 1,000 population. We have a real cultural mix in our local boroughs, and the HIV services don't just manage the people who are living locally, but also people who are working just on the other side of of Big Ben, out in the city. People who are visiting the city too, they come and use our services. So that's me, that's our hospital. We've been running an HIV gym group at the hospital for about 10 years. It's a twice-week, 1-hour exercise programme, and people are invited to come for 10 weeks. We are advising people to be doing exercise outside of this environment. It's just to be doing exercise in the gym group at those times. So our aim is to start getting people into exercise and looking at exercise as a lifestyle choice, and there's a focus of onward referral, and I'll talk a little bit about that in a minute. I accept referrals from a variety of HIV specialists, and again I'll talk to you a bit about that in the pathway for the research. People can't just come to the gym group because they want free exercise, unfortunately. There needs to be a referral reason, but really you can pull in a referral reasoning from anything. So increased cardiovascular risk, if someone's suffering with lipodystrophy, if they've got high BMI or low BMI, reduced bone density, deconditioning maybe after a period of hospital stay, and low mood. So this study is about adherence. Adherence is someone's active decision to participate or to uptake a treatment regime. And adherence is obviously very important for any treatment regime to be successful. And what we find is that with our groups of patients, that adherence often falls below what is recommended. So within our exercise group, what we did an observational cohort study. This was before my time, but my peers did, and they were looking at what characteristics influence adherence versus non-adherence to exercise in our HIV-positive populations. And what they found was that age, gender, baseline CD4 count, fitness level, or reason for referral didn't influence adherence. However, ethnicity did. So those who are white British were much more likely to be adherent than those who are black African. We also found that perceived well-being influenced adherence. We use the FAHI as an outcome measure within our gym group. For those of you who don't know it, it's a functional assessment of HIV infection. There's 5 domains, and it's looking at perceived quality of life over those 5 individual domains. An increased score indicates better perception of health, and I'll revisit that in a minute. So what we thought was that there are certain factors which influence people's adherence, and what we wanted to look at was psychological and socio-economic or cultural factors which lead to adherence versus non-adherence to exercise programmes, which is obviously very important to us as physios, but for the wider world as well, medical treatment too, in people who are HIV positive. And I found it really interesting what Stephen was saying earlier about viral suppression being only achieved in about 25% of the population. He was leading to adherence issues too. So this kind of information links very nicely with my study. So the previous study was conducted up until about 2008, and from that point we started planning this next stage. Data collection started in February of 2010 and went on till October of last year. Analysis has been ongoing since that point, and the first time I brought this to the wider world's attention was in July last year when I presented at the National Rehab and HIV Association meeting. Okay, so the hypotheses of this current study, the first one's very easy. The relationship between adherence to exercise and medical treatment is stronger amongst those with a more favourable view of the goal. The second one's a little bit more tricky, and I'll go into that in a bit more detail. The way that people think about the underlying goal of treatment explains their adherence behaviours over and above the behaviour of specific thinking. So let's just take it away from this context and think about a teenager who's considering taking up smoking. They may think about the behaviour of smoking, that it's not very nice, that it smells, that it's expensive, but if the underlying goal is that it's going to make them look cool in front of their friends, some of those guys are going to pick it up. And so if we then take that back to this particular study, the behaviour is taking the medication or doing the exercise, and the goal is then following doctor's orders or becoming well. So the trial pathway, people are referred to me for exercise for a variety of different reasons. If they were referred in, normally what I'll do is have a one-to-one clinic and I will screen them for what's the most appropriate service for them. Do they need to be doing a bit more exercise? Do they need to go to Zumba classes in the community? Do they want to be going and doing some swimming? Or do they need a little bit more of a hand-holding to come into our gym intervention programme? It's during the working day and it's twice a week. So if they're suitable to come to the gym programme, they'll come for a 10-week period, and then the plan is to refer them on for ongoing exercise afterwards. If they were suitable for the gym intervention, everybody was screened as to whether they were appropriate to come into the research trial. So the inclusion criteria would be that they were between 18 and 55 years old, that they were on antiretroviral medication. They had sufficient head hair to collect a small sample, because we were going to test that for the antiretroviral medication to objectively quantify whether they were adherent to the medication. I say head hair. I stretched to auxiliary hair. I wasn't going anywhere else. And the other things were that they had sufficient English and cognition that they were going to be able to complete our battery of tests. And if they were suitable, they were invited. Just a little bit of a summary here. 43 were recruited. 4 dropped out before they got to T2. 39 were unsuitable because they didn't meet our inclusion criteria for a variety of different reasons. 12 declined, and those who declined did so because they couldn't potentially commit to coming to 20 sessions, and that was part of it too. What we found, looking at the cohort, there was about a 50-50 split between our 2 highest prevalence groups, MSM and SSA. So, and when I say SSA, that's Sub-Saharan African born. The outcome measures I will talk to you a little bit more about in a minute, but the information about beliefs came from the questionnaires and computer-based test, and then we did our normal standard battery, which was the FAHI, so our perceived quality of life, as well as anthropometrics and weights, etc. So the novel aspect of this trial was that outcome measures were collected whether or not the participant attended their available exercise sessions. I said that specifically, thank you, at the start. And so when they did this, it meant that we could... Sorry, I've just been thrown. We collected that whether or not they came to the exercise sessions, and they were remunerated for whether they for coming to the outcome measure sessions. The project assessed their beliefs about the underlying goal and the goal-specific behaviours, and the beliefs and the adherence patterns were united, which hasn't been done before. So I haven't got a massive amount of time here now, but I'm just going to talk to you about our objective markers and our subjective markers for their adherence, and then our factors contributing to adherence. So the number of sessions attended was our objective marker for someone's exercise adherence, and their subjective marker was their self-report, including exercise diary. So they told us what they were doing and completed a diary too. For the medication, our objective marker was the analysis of their hair sample, and a paper's been published on this as it was a novel way of reporting it, and subjective marker was a self-report. And the implicit and explicit attitudes, I could spend hours going into further, but if someone wants to ask me about that in a minute, they can do. So sample characteristics, important things here, mean age was 44, range 32 to 55. Exercise adherence, we got a good spread. We got people who came to none of the exercise sessions and people who came to 20 and all those in between. So we got a good spread of the understanding of what was going on with them. And participants were then characterised as being low, medium or high attendance. So there's an awful lot of data to collect, but I can give you some tentative conclusions. Gender had an influence on the efficacy to follow orders, so men were less likely to want to follow orders than women were. Also, age had an influence on the efficacy to follow orders. So those who were older, and when I say older, I'm meaning up to 55, not older age, were more likely to not to want to follow orders than their younger counterparts. And it also had an influence on exercise. So when thinking about strategies to help to support people, we may need to be looking at targeted age-related interventions as well. Conscientiousness is a personality trait linked to exercise self-efficacy with exercise adherence. These aren't massively groundbreaking things, but it's good to have the information now that we can then go away and work with. I'm going to skip over this slide, but we can talk about the links with their perceived well-being again if you'd like to ask me later. But the next steps, obviously we need to do full data analysis and conclusions. We need to disseminate further papers and presentations. We need to refine our data collection strategy and streamline our protocol. It took about an hour to an hour and a half for people to be giving us this information, which was a lot of time. People may have got very tired doing that. So we need to pull it back to the things which show us the most information. With a long-term goal of identifying beliefs which influence the intention to exercise or take medication in HIV, and to develop interventions which aim to modify beliefs responsible for poor adherence patterns. Those are our papers if you ever want to have a little squiz. And yeah, that's me.